morning, everybody. We're going to get started momentarily, all right? We're doing this program. MS Views and News is doing this program today, okay? So we wanted to give you great speakers. Thank you. We wanted to give you great speakers. We got Dr. Shah, who's here. Dr. Shah's from Ohio Health MS. He's bringing you a discussion on bladder issues and multiple sclerosis. And then, of course, you're going to listen to what's his name? Aaron Boster? Yeah, that's the name. All right. He'll be here, too. I think he even made it here today just to see you all. So, again, let's get started with today's program. Let's welcome Dr. Ketul Shah. Okay, come on up. From Ohio Health. He's going to speak to you about bladder issues.
Good morning, everyone. Welcome. My name is Ketul Shah. I'm a urologist with Ohio Health. First of all, I want to thank Stuart and MS Views and News for allowing me to come and talk to you about how bladder conditions affect patients with MS and how we as urologists can be part of your team to help you and make sure that you all do well. Just to give you a very brief introduction about myself, so I'm a urologist. I graduated from Ohio State University Medical Center. I did a fellowship in female urology and neurourology in Denver, Colorado. And then I worked at OSU with Dr. Boster for several years, and now I'm with Ohio Health. So during all these years, I did come across several patients who have neurological issues, spinal cord injury, Parkinson's disease, MS, and it's one of my passion and interest to work with these patients and see how best I can help them. So let's go ahead and get started and talk about how bladder gets affected in patients with MS. I have no disclosures for this talk. Now, before we really get into why, as a urologist, I'm here to talk in front of all of you, let's first of all talk about what is normal function of the bladder. Now, first of all, right now we are all sitting and listening to this, discussion. Our bladder is getting full with urine. So all the coffee and water that we had this morning, the kidneys is making urine, and it's all stored in the bladder. Now, if you realize bladder is basically nothing like just a balloon. It's pretty elastic and stretchy, and it can keep holding urine till it starts getting signal to the brain. Now, normally our bladder can hold urine to about 300 to 500 cc, and it keeps sending signal that it needs to go. Now, our brain can actually override and say that, no, it's not time to go, and let's just keep holding. Till you reach to a point where okay, I think it's better I go now. At that point, you will go to the bathroom, you'll relax, your detrusor muscle, which is your bladder muscle, will actually make a contraction or a squeeze, and you'll pass urine. So that filling and emptying goes on the entire day, depending upon how much amount of a fluid you drink and things like that. Now, if there is any interruption in the process of storing, that will lead to patients complaining of trouble holding, or what we would discussion as storage dysfunction. At the same time, when we try to pass urine and we have difficulty in starting or completely emptying the bladder, it leads to trouble emptying or voiding dysfunction. And some patients actually have a combination of storing as well as emptying, and that is what we would call a mixed dysfunction. So patients with MS can have various degree of bladder dysfunction depending upon their level of disease, the progression of their disease, etc. Now, why are we talking about bladder dysfunction in an MS conference? Because of a very important thing. Now, this was a very interesting study that was done in 2011, I believe. Yeah, and this was an online study where newly diagnosed patients were asked whether they have any form of bladder dysfunction. And more than 1,000 patients kind of responded to this study, and what we found is that more than 90% of the patients actually had some form of bladder dysfunction from the time of their diagnosis till the time of getting their treatment. So again, this is a very important number, that more than 90% of the patients have some form of bladder dysfunction. And it's important that you discuss with either your MS specialist or your primary care physician that you need to be plugged in with a urologist who can help you with that. Now, these are the most common reasons why patients are referred to us. As I mentioned, voiding dysfunction is present in almost 90% of the patients. The couple other things that we do help patients a lot, one is recurrent urinary infections, and we'll talk a little bit about that. Again, it's a huge problem in MS patients. And sexual dysfunction, that's again overlooked several times because you have so many other different things that you're dealing with. This kind of becomes a secondary thing. And as we get more comfortable, we talk about those other issues as well. Now, first, let's talk about what is storage dysfunction. Now, if you look at this here, and if you have one of these things, then you definitely is following with storage dysfunction. Now, these phrases that I've taken it from my patients, typically they would tell me that I got to go all the time. I have to have this constant urge to pee, even if I have just passed urine. Sometimes patients will come and tell that I'm up all the time at night. I have trouble holding and trouble making it to the bathroom and end up having an accident. And this is my favorite one. And this is probably many of you have told me that I know each and every toilet in this town. And again, it's pretty common. Now, if you have experienced any of these symptoms, then you are probably having what we call overactive bladder. Now, what's overactive bladder? It's a fancy term that has been designed to tell that you basically have a trouble holding urine. Now, there are about 3 or 4 different components of overactivity. Now, if you are passing urine more than 8 times during your awake time, then you are having daytime frequency. If a person is getting up more than twice at night, then they have nocturia. What is urgency? So if you have this certain urge to go to the bathroom and you are unable to hold it, that's urgency. And if you are not able to make it to the bathroom, that's urgent continence. So these symptoms put together, we would call it as overactive bladder. On the other hand, some patients will come and tell us that they have trouble starting the urine. They actually go to the bathroom. Sometimes they sit down. They would wait for 30 seconds, a minute or 2 before they can really start passing urine. Some patients say that I pass urine, but I have to really strain. I have to push to pee. Sometimes they would say that I don't think that I'm completely empty the urine. By the time I finish, I have to go back again in 10 minutes and pass urine because I just don't empty the urine. And in extreme cases, patients will come and say that I just can't pee because I'm in complete retention. So these are trouble with emptying dysfunction. So the common terms that we use in our world is hesitancy, that is trouble starting. Straining means that you have really strained to empty your bladder. Trouble emptying, and complete retention where you have just stopped passing urine. Now, when patients are referred to us to our office for evaluation, it's a pretty lengthy process. In your first visit, we really go in detail about what kind of voiding dysfunction you have, whether it is trouble storing urine, whether you have trouble emptying, or whether it is a mixed dysfunction. That's the most important thing that we want to try and find out from you. How much is the trouble bothering you? Especially in those patients who have urinary incontinence, we want to find out whether we are talking about just few drops of urine leakage or we are having complete urinary incontinence. The next important thing is how much this bothers you in your daily life. Have you reached to a point where you have stopped going to your social engagements? A lot of time, patients would say that I have stopped going to church. I don't go and meet my friends anymore because I'm just embarrassed that I'm going to end up having an accident. So these are very important things for us to find out how much this bothers you. Next important thing, apart from just bladder issues, are you having other issues like infections, bleeding? What other issues that is happening? Now, if you have seen other urologists or have you talked with primary doctors, or sometimes even your neurologist will start you on some medications, whether those medications have been effective. Are you having side effects from those medications? So those are the things that we want to find out when you come and talk to us. Now, there are 2 important things that I personally think are most important when I first meet our patients. First and foremost, what's the goal of therapy? What do you want to achieve? Do you want to become socially continent? Or you want to reach to a point where you are completely independent and not having to use things like a pull-up or a depends and things like that. And lastly, what's the social support? Because that's again a very, very important thing. A lot of patients that I see in practice don't have good social support. They don't have family or friends helping them. And that becomes a very important thing for us to recommend what treatment is best for that patient or what is not. Because if you really prescribe very elaborate treatment and patients can't follow that, that's not going to work out. So those are the important things that I really look at very carefully before I tell them like this is the best for you and this is not going to work for you. We do use a lot of questionnaire now. This is a questionnaire that most of the time a newly diagnosed MS patient will fill up when you go and see your neurologist. Apart from that, there are a couple of questionnaires where we use specially in women and men about their voiding dysfunction. We also like to use a lot of voiding diary. So voiding diary is basically for a period of 3 to 5 days, you're going to essentially write down on a piece of paper how much you are drinking, what kind of liquids do you drink, when do you have urgent continence, etc., etc. So that gives me a little bit of a snapshot, what's happening in your life on day-to-day basis. We also do some simple office tests, like we will check your urine, we will do a quick bladder scan, make sure you're emptying your bladder. In some select cases, we will probably do like an ultrasound of your kidneys, make sure that the kidneys are doing well, things like that. Now, there are a couple of tests which are very important for us, and I think we would do this test in very select patients. These are the patients where I feel that doing this test will actually going to change how we manage these patients. So one of the tests is called a urodynamics test, and second is called a cystoscopy. I mean, in this crowd, actually, I see some patients who are very familiar to me, and some of you have already done this test with your urologist. So what's a urodynamics test? So this is a very simple test. In my mind, we are trying to recreate what's happening to your bladder in my office. So you come to our office, we will artificially fill up your bladder with some fluid and try to understand how much you can hold it. Are you getting spasms in your bladder? Are you getting accidents when the bladder gets full? When the patient is completely full, we just ask them to pass urine and see how well the bladder muscles are working, how well the sphincter is working. It's about a 15-20 minute test, very important, simple test, not painful, but it gives a wealth of information that actually a urologist can determine how to treat the patient. The next thing that some patients will require is cystoscopy. Now, cystoscopy is simply also called as the camera test of the bladder, where a very thin, flexible scope is passed in your bladder after giving a local anesthetic, so that we can actually evaluate or examine the lining of the bladder, looking for things like bladder stones, bladder tumors, enlarged prostate in men, etc. Again, these tests are not required for every patient with MS, but select patients who are not getting improved by initial interventions will actually benefit by doing cystoscopy. Now, how do we manage these patients? So the management typically would depend what are we dealing with. So is it primarily an issue of trouble holding or trouble emptying? So let's first talk about patients who have trouble emptying. So these are the patients who in my office will have high residual volume. So they have about residual of about say 300, 400, 500, or they are just in complete retention. What can we do for them? First and foremost, I think most important thing is patient education. We try to educate the patient, why are they having these symptoms? What's exactly going wrong with their bladder? Is it the bladder muscles are weak, or is it the sphincter muscle that's not functioning well? So that's the first important thing, is to educate the patient. Second thing, which is I think very important to do, is called time voiding and double voiding. Now, double voiding is something that is when a patient goes to the bathroom to pass urine, once they're done, we ask them to wait there, either sit there or stand there for a few extra seconds and try to pass urine one more time. In women, we usually instruct them to try to wipe themselves to see if that would initiate another voiding reflex, and then patient can pass more urine. So just staying a little longer in the bathroom, trying to pass second time, can actually make a huge difference. Third thing is Creed maneuvers. This is an option where patient would actually press on their lower belly, or they would lean forward to see if they can initiate or pass some more urine. And this can be very effective, especially in women. This can make a huge difference as well. Now, there are some medications that we would like to try, depending on the situation, depending on the patient, where it sometimes can make an improvement in how patients pass. One of the common medication that we have tried, and I'm sure some of you have tried, is called Flomax or tamsulosin. So this is something that we use typically for men who have enlarged prostate. Some women can also be beneficial by taking medications like this. Another medication that we would try is called bethanocol or urocolin. Now, this is a medication which can actually help to make a little stronger contraction of your bladder muscles with the goal that you can empty more urine out. Medications are not always useful, but certainly it's worth trying for at least for a period of time. Now, next important thing which I want to talk about is self-catheterization. Now, some of you may have already done this, but this is a very, very important part of the entire management. Those patients who cannot empty their bladder or they are in retention, this is the most important treatment option for them. A lot of time your neurologist will actually teach you, or their nurses will teach you how to do the catheterization. Now, the first important thing is that who can do catheterization? Patients themselves can do it, or a caregiver can do it. As long as the patient has dexterity, motivation to do this thing, this will be the best friend that you can have to control your bladder. The main advantage of doing self-catheterization is that it's going to give you a lot of independence how you manage your bladder. And those patients who do not need to have catheters, they can be actually sexually active. So those are important things to think about when you talk about self-catheterization. How often do you need to do catheterization? That actually will depend upon how much fluid you are taking. Our goal is usually to make sure that your residual urine is usually about less than 400 to 500 cc. So give and take, usually about 4 to 6 times a day is catheterization schedule that is required for each patient. There are various different kinds of catheters, and those who have used catheters will actually know a lot about this. You have pre-lubricated catheters, or catheters which can be used and throw, or catheters can be used again. Different kinds of catheters are available. There are some examples that I want to show you here. This is called a Speedy Cath, which is made by Coloplast. There's another catheter which essentially comes with its own bag. So you would just collect the urine in that and you would discard the whole thing. So a lot of these different catheters can be used depending on your need. When you come to our office, we'll actually give you like a sample kit and various different catheters you can trial and see which one works best for you. Now, all your insurances will definitely cover the catheters, so important to remember that you don't have to buy catheters just online or somewhere, but your insurance should be able to pick up that as well. Now, those patients who are either unable to perform catheterizations or they have some disease of their urethra, like having a stricture or a scar tissue, they will end up requiring a catheter. Now, in my mind, personally, Foley catheter or suprapubic catheters is an absolute last resort. When patients have tried other different things and nothing else works, then we would use catheters. And partly because these catheters will actually has a lot of problems. Catheters will lead to infections, stones, bleeding, all sorts of issues. But again, in some cases, you have no other options but to go to the route of getting a catheter. Any questions before I go ahead? All right, so let's talk about next. This is another important issue. What happens when patients have trouble storing urine? So these are the patients who have a lot of frequent urinations, they have urgency, they end up having an accident before they go to bathroom. Most important thing is behavioral thing, behavioral modification. These are very simple measures that you can do on your own to try to improve the situation. First and foremost is try to do time voiding. Now this is very, very important. Patients with MS typically will have some kind of issues with their mobility. The moment they get this urge to go to bathroom, it takes usually 30 seconds, 45 seconds, a minute before they really make it to the bathroom, and that's when they start up having an accident. So it is critical, it is very critical that they follow time voiding. What's time voiding? So it depends upon the amount of fluid you drink. You may decide to go to bathroom every hour, every couple hours. And most everybody has a smartphone, so put an alarm to remind you to go to bathroom every 2 hours. That's the simplest thing you can do for yourself. And that will make a huge difference. Time voiding, remember that. Second thing is look at your diet. Is there something in your diet that you're doing a lot that's make you go to bathroom all the time? Are you drinking too much coffee? Are you drinking a lot of alcohol? Are you taking too much iced tea? Things like that. They will actually going to stimulate your bladder and make you go to bathroom a lot. So you can make small adjustments in what you eat and drink. That will make a huge difference as well. Now patients would say that I get 4, 5, 6 times at night, but how much liquids do you drink before you sleep? Some patients say that, well, I drink a couple beer before I go to before I sleep. Sometimes they said I drink 2 or 3 glasses of water. That's not going to help you. So try to reduce the amount of fluid before you sleep. Usually we instruct them to drink as little as possible, maybe about a glass of water to take your medications before you sleep. So these things will make a huge difference about making your management. Now, once you have tried these simple things and it's still not helping, then your physician will actually prescribe you medications. Now, there are two broad class of medications that we use for bladder. These are called overactive bladder medications. The most common, what we call, is an anticholinergic medication. So it works on a very specific receptor called muscarinic receptors. These are present on our bladder, and they can actually slow down the activity of the bladder muscles. There are various examples of these muscles. Some of you may have already tried this medication. There are total 6 medications which are out there in the market. And that actually explains why there are so many medications, because not one medication is good. A lot of time we would start the patient on one medication, we would switch to a different one because either they're having too many side effects or it is too expensive for their insurance, etc. Most of these medications have common side effects like dry mouth. Constipation is another big one. Now, in elderly patients, we are getting very careful because some of this medication actually can cause confusion, hallucination. So we are very careful to try to make sure that these medications are not causing side effects. There's another medication, some of you may have already tried this, it's called Mirabetriq. It's out there for last 10 years. Again, another good, nice medication. It works on a totally different receptors compared to the previous group. It works on what we call a beta-3 agonist. But the ultimate response is just to cause relaxation of your bladder muscles. It's available in 2 doses, 25 and 50. It does not have any of the side effects that is present in the previous group. So this is kind of the go-to drug for all urologists currently. Now, the biggest challenge that we all face is the cost, because it's not generic at this point. A lot of insurance will not cover it. So that's kind of where a lot of time we would do actually a prior auth to see if their insurance would cover this medication, and hopefully we can give it to you. Now, those patients who have tried behavioral modifications, they have tried to change their diet, they have tried a couple of medications, and they still continue to have symptoms, then we would call them refractory. They are refractory overactive bladder. And many patients with MS will actually fall into this category. Now, we have 3 excellent treatment options for these patients. One is injecting the Botox in the bladder muscles. Another one is called a bladder pacemaker device or bladder stimulator. And lastly, there is an acupuncture treatment that we do in our office. So I'll talk about this a little bit. I think this makes a huge difference. I would imagine that all of you are pretty familiar with Botox at this point. A lot of your neurologists would inject Botox into your extremity if you are having a lot of spasticity. Some people get Botox injected if they have issues with migraine. So what is Botox? Botox is basically a neurotoxin. It's derived from a bacteria, and when it is injected into any muscles in our body, it kind of leads to paralysis or weakness of that muscle. Now, when it is injected into the bladder muscles, it will reduce the spasticity of the bladder muscles so that you don't have to go to the bathroom so frequently. Now, how is Botox done? Botox is an extremely simple office procedure. We typically do it in our office, where you will come to our office, we would give you some numbing medication in the bladder, and then we would pass a small camera in the bladder, and it is injected into the bladder muscles by using a very small needle. We use different dose based on the amount of symptoms that you have, or if patient is already doing catheterization, we would use either 100 units or 200 units based on that. Botox will last for about 6 to 9 months. So if you had a good response, then you're looking at getting a treatment about twice a year. One other important thing is that Botox is covered by the insurance because it is approved by the FDA. So insurance will typically cover the Botox cost as well. There are a couple of minor things that we need to always remember, that Botox sometimes can lead to infection in your urine. So those individuals who have a lot of infection, we would try to shy away from giving them Botox because we don't want to give them more infection. And there is a very small risk of patients developing retention, means that they cannot empty their bladder completely and may need catheterization. So this is something your urologist will look into it before they would recommend you Botox. Another treatment that is very popular in the recent time is what is called a bladder pacemaker device or bladder stimulator device. Now, it goes by the name of Interstim therapy. It is essentially a neuromodulation where a small implant is placed in the sacral region, that is the tailbone area, and then there is a small battery that powers the implant, which can actually help to control how the activity of the bladder is controlled. In the past, we would not recommend this device because these are not compatible with MRI scans, and many of you require MRI on a very regular basis. So in last about 6 months or so, now we are getting devices which are going to be MRI compatible. So many of you patients with MS will be actually eligible to get a bladder pacemaker device, which is actually a much better therapy compared to Botox, but certainly it's an option as well. Another therapy that we recommend sometimes is something called as an acupuncture treatment. It goes by the name of percutaneous tibial nerve stimulation. Now the concept is that there is a nerve which is present close to our ankle. It's called a tibial nerve. And if you stimulate that nerve with a small TENS unit, that can actually help to control the bladder symptom. Now, this is a little bit long, extensive therapy. You would come to our office once a week. We would do a half-an-hour treatment, and that will go on for about 12 weeks. And that's the initial treatment. Once that treatment is completed, then you will come to our office at least once a month to continue the therapy, and that would continue to help you with your symptoms. So this is another option. The good news that it has absolutely no side effects. The only problem is that it's a very slowly acting treatment, and it does require multiple visits to our office. So that becomes an issue sometimes, but it's a decent option. Now, researchers are at this point working on getting what is called as an implantable tibial device. So it's a very small device which almost looks like a little penny that is inserted close to the ankle. And it's a very minor office procedure that can be performed, and then patient can do stimulation at home on a daily basis. So they're going to have a little device which will look like a sock that you put it on your ankle, and you will stimulate the device at home for about half an hour every single day. And that's going to be your stimulation, and that's going to be your device. So people are working into these kind of things, and I think in future things are going to get even simpler as with these devices coming on. Now, we're just going to briefly talk about mixed voiding dysfunction. So when patients have a mixed symptoms, trouble holding, trouble emptying, that becomes a very, very complicated situation. And that's where I would typically perform a urodynamics to decide what gets precedence. How do I manage these patients? Do I do medications? Do I do catheterizations? Do I do both? Is this patient good treatment option? Is Botox? So a lot of these patients will actually require a urodynamics. Also, these patients will require long-term management. So your urologist probably would see you every 6 months or a year to make sure that they follow along and see how their symptoms change. Now we're going to switch gear and we're going to talk a little bit different. So another important thing that I see in my practice a lot is recurrent urinary infection. I'm sure all of you at some point experience urinary infections. Now, urinary infection is extremely common in MS patients. It is a very important thing because when you have a urinary infection, your bladder symptoms will worsen right away. And a lot of these patients will actually not experience the typical urinary symptoms like burning, discomfort. And their symptoms could be very different, like they will actually have a foul-smelling urine or a strong odor. Sometimes patient's family member would say like, he's not behaving his usual self. Patient is extremely upset, patient is either confused, delusion. Those are the atypical symptoms that we would have for urinary tract infection. Sometimes when patients come to our office for urinary infections, we would actually do some other testings like ordering a CAT scan or an ultrasound to look for things like kidney stones or a blockage. Some patients will also require a cystoscopy to check their bladder, make sure that they don't have recurrent infections and they would have much longer treatment. Now, what can we do for them? Most importantly, we talk about increasing their fluid intake so that you can flush the bladder, and we try to follow as much of the hygiene precautions as possible. In sexually active women, we always ask them to urinate after having intercourse. There are several natural ingredients that can be used by patients which are over the counter. The common one that we use typically is a cranberry extract. You can use either a cranberry juice or cranberry pills. Again, they are very helpful to prevent UTIs. This is something that you can take on daily basis. There are some reports that we would use vitamin C, things like probiotics. Those are all very helpful to prevent infections. In women, especially once they have reached menopause, there is definitely a lot of role for us to prescribe hormone therapy. And some of you may have already discussed with your gynecologist that a hormone therapy would be very helpful to prevent infections. And there are various formulations that we use. Examples would be things like Premarin cream, estrus cream, small vaginal tablets like Vagifem. Those are again very helpful to prevent urinary infections. Now, how do we use antibiotics? Since UTIs are so common in patients with MS, antibiotics becomes another important part of your management. Now, we have different ways of doing antibiotics. Either we can do self-start therapy. So self-start therapy is an interesting concept. This is where the patient is in charge of treating their UTI. The moment you recognize that you have symptoms of UTI, you will go to the lab, drop a urine sample, and your urologist would actually prescribe some antibiotics to your pharmacy, which is standing order. You will go and get your antibiotics and start right away. But the most important thing is to drop a urine sample so that we can find out what bacteria you got. So that's self-start. You are in control. Very important. Second thing, those patients who have tried other things and they keep getting UTIs, we would sometimes put them on a daily dose of low antibiotics, which would go on every night for about 3 to 6 months. In select cases, that does the job. Some patients, especially young sexually active women, we would prescribe them post-coital antibiotics. So this is where the patient would take an antibiotic pill within 2 hours of having sexual activity. So that can prevent from having UTI as well. So depending on the case, depending on the situation, we have several options that we can offer you to prevent your UTI. Another interesting thing which is fairly common is those patients who are doing self-catheterizations, they keep getting UTIs. This is another big reason why patients get discouraged and stop doing catheterization. We would encourage them to use different types of catheters. So those which are pre-lubricated hydrophilic catheters are very important to prevent UTIs. We would also use a medication called Hiprex or methanamine. This is my go-to drug when it comes to urinary infections with catheterization. It's used as a medication as a urinary antiseptic, and it can also prevent a lot of UTIs. So this is again a very good drug that can be used if you have UTIs with catheterization. Lastly, I want to just talk about a couple other things. One is sexual dysfunction. This is again a very common topic that comes along, especially patient has been doing well, their MS symptoms are well controlled, things are going well. This is when patients start talking about their other issues. Male patients with sexual dysfunction, we have several options that we can offer them. Some of you may have already tried this. The most common examples is things like Viagra, Cialis, Levitra. There are several medications that we can write. In the recent time, medications like Viagra is actually becoming generic. So remember to ask your primary care or your urologist to write for you because the cost has definitely gone down and many patients can get at a much, much affordable cost. Those people who have tried medications not having good response, we try other things like a vacuum erection device. This is again something your insurance will cover, so you can ask for that. Some patients will actually require more therapy like doing a small injection into the penis to get an erection, so that can be done as well. Lastly, if patient is really motivated and want more stuff, then we can actually do what we call a penile prosthesis. That is a surgical procedure, but again works pretty well. Another important thing which I've been working a lot recently is female sexual dysfunction. This is a topic which has not gone a lot of momentum. A lot of patients don't talk about this. But when you really sit down and talk about it, there is a lot of patients would say, yes, this is a problem, but God knows what to do about it. So we talk a lot about counseling, physical therapy, behavioral modification, couples therapy, things like that. We do work with some therapists who actually can really make a huge difference about this issue. There are a couple medications which have come in the market recently. There is one called flibanserin, which goes by the name of Addy, which is mainly used for in a younger women who have what is called hypoactive arousal disorder. So these are the patients who actually have lost interest in sexual activity, and they can actually benefit by taking medications like this. It's called Addy or flibanserin. Some women, especially if they are postmenopausal and they have trouble with female sexual dysfunction, we will actually prescribe them testosterone. And we can have testosterone as a gel or a patch. That can make a huge difference as well. So again, it's important that you talk with your provider about these issues if you're having, because there are some options that we can definitely offer you. So again, I just want to finish here, so we have some time for some questions. Again, bladder dysfunction is very common, and I'm pretty sure all of you at some stage of your disease will experience some issue with your bladder, and it's important that you talk with your primary care or your neurologist and see if they would plug you in with some urologist who's actually have interest in working with MS patients. A lot of these things are simple management, changing your diet, the time voiding, double voiding, simple things like that will make a huge difference, and which can actually solve a lot of problems. Sometimes patients will require medications. Some patients will require things like Botox injections or neurostimulators, depending on how bad is your symptoms. And lastly, I feel that urinary tract infection is something overlooked, and it should be very, very aggressively managed in patients with MS, because that will make a huge difference when it comes to getting your bladders controlled. So I'm going to just leave my contact information here. If you have any questions, if you want to give us a call at any point. But again, I want to thank Stuart for allowing me to come and talk to all of you. I really enjoyed this part, and if there are any questions, we'll go over that now.
Let's give Dr. Shah a round of applause, right? So I'm going to ask, whoever's got questions, please raise your hand.
Do you feel like this is more prevalent in MS?
You're talking about bladder dysfunction?
Bladder dysfunction.
Yes, it is definitely more prevalent in patients with MS.
What do you think causes it?
That's a good question. So a lot of, like in my first slide, we talked about how the brain is in control of the entire process of voiding. So a lot of time when the bladder gets full, it sends signal to the brain, and the higher centers in the brain can actually override those signals. And a lot of this information back and forth between the bladder and the brain is actually without our knowledge. It's involuntary. Now, I'm sure you know that MS is a condition where essentially we would lose the neuronal function that happens from the brain. And depending upon the level of your MS lesions, whether it is in certain parts of the brain or whether it is affecting the spine, that information between the bladder and brain gets discarded. And that's part of the reason why this happens. A lot of patients with MS will also have bowel dysfunction. It's the same theory. And the other interesting thing is that as patients' MS lesions will change, so let's say a patient had lesion in brain and now they suddenly start having lesions in their spine, their bladder symptoms will actually change from one extreme to the other extreme. So initially if they have trouble with frequent urinations and urgency, now they will go to a point where now they're into retention. So that's another interesting thing that is something that happens.
Wait, over here next.
I have a question about Botox. At what point would a patient consider Botox if they've tried other means, medication and electrical stimulation? And then what is the prevalence of having to catheter, you know what the word
Yes.
is, after doing the Botox?
That's a very good question. Thanks for asking that question. So first of all, when do you think it's time to do the Botox? So we talked about this thing called a refractory overactive bladder. So by definition, if the patient has tried at least 2 medication, then you are considered to be refractory. And this is something that your insurance will kind of mandate before they really approve you for Botox. So we usually like to try the patient on at least a couple of medications for about 4 to 6 weeks and see whether their symptoms are not improving or they are experiencing side effects. Patients should have also tried behavioral modifications, they have changed their diet, and at that point, technically they are eligible to get Botox. Now, when do you want to do Botox? That obviously is dependent on the patient and the discussion with the provider. Now, what is the risk of retention? That retention is about 6%. Now, if you really think about what is 6%, 6% is 1 patient out of 20. So 1 patient out of 20 will have retention. Remaining 19 patients will not. So again, I usually have a positive attitude. I tell patients that you're going to be those 19 patients who will do just fine. Now, as a urologist, a lot of time when you come to our office, based on your symptoms, based on your urodynamic study and the residual urine, if I feel that you are kind of borderline, then we would make sure that we would have a much better discussion that, if you go into retention, what are our options? Are you able to do self-catheterization yourself? Do you have a family member who is willing to do it? Those are important things to look into it before really do your Botox.
Yes, I self-catheter, and I've had more UTIs than I'd like to mention. I would like to hear about the low-dose antibiotic that you mentioned before, though.
Yes. So first and foremost, it's important to understand UTIs with catheterization. So there is a concept of bacterial colonization. You know, sometimes your doctor will say, well, I'm checking your urine, I see some bacteria, but you have no symptoms. That means that you're colonized, means you have bacteria in your urinary system all the time. That doesn't mean that you need to get antibiotics. Remember that if we give you more antibiotics, there is a chance that you're likely to develop resistance, you're likely to develop some other things like C. diff, which can again be very detrimental to you. So it's important that we treat your clinical symptoms. We treat you, not the results. That's number one. Number two, so if you have symptoms of UTIs and you have persistently having the same bacteria each time, for example, in E. coli, then you will be a good candidate to start on low dose. So low dose antibiotics is something like nitrofurantoin, a Bactrim pill, etc., that you would take every night before you sleep for roughly about 3 to 6 months. And at that point, we would stop and just monitor your symptoms and see what happens. Another important thing that I use a lot was that medication I was talked about called methanamine or Hiprex. That's a medication that you can take on daily basis. And essentially, it leads to a gas called formaldehyde, which can clean the bladder. It's almost like doing a chemical bleach of your bladder. And that can also prevent a lot of UTIs if you're doing catheterization and have issue with UTI. So you got a lot of good options there.
Any other questions? Well, then let's give Dr. Shah a round of applause again. Thank you. Thank you very much.